Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Trastuzumab-Associated Cardiac Events at 8 Years of Median Follow-Up in the HERA Trial, Big 101, by Evandro de Azambuja et al. My name is Dr. Ed Romand, and I'm a medical oncologist at the Markey Cancer Center at the University of Kentucky in Lexington, Kentucky. My oncology specialty is breast cancer. First, let us summarize the design of the HERA trial and the cardiac follow-up data as presented in the paper. HERA is a large international trial conducted in 39 countries in which 5,102 patients who had completed adjuvant chemotherapy and radiation if indicated for operable HER2-positive breast cancer were randomly assigned to observation or either 1 year or 2 years of adjuvant trastuzumab. There are about 1,700 patients in each arm. Now, in terms of placing this study in the context of the other large adjuvant trastuzumab trials, there are two important points to make about the patients who were enrolled in HERA. The first is that 96% of the patients in HERA received neoadjuvant or adjuvant chemotherapy with an anthracycline, plus or minus a taxane prior to enrollment. The median time, however, after completion of chemotherapy until the first dose of trastuzumab was about 3 months. The second point is that after completion of all chemotherapy and radiation, patients had to have a left ventricular ejection fraction of at least 55%. Therefore, patients whose EF dropped below 55% after anthracycline chemotherapy are not included in HERA. A primary cardiac endpoint in HERA was defined as any cardiac death or New York Heart Association Class 3 or 4 congestive heart failure. For other patients, a secondary cardiac endpoint was an absolute decline of at least 10 percentage points from baseline in LVEF to a value under 50% that was either symptomatic or asymptomatic. Acute recovery from a cardiac endpoint was defined as 2 or more sequential LVEF measurements above 50% following a cardiac event. In this trial, asymptomatic patients were monitored by clinical assessments and either MUGA or echocardiogram at 3, 6, 12, 18, 24, 36, and 48 months after enrollment, and then annually between years 5 and 10. So what are the results? At a median follow-up of 8 years, there were 3 cardiac deaths in the 2-year trastuzumab arm, none in the 1-year arm, and 2 in the observation arm. Severe CHF occurred in 0.8% of patients in each of the 2-year and 1-year arms, and none in the control arm. Short of severe CHF, significant LVEF drops were seen more in the 2-year arm at 7.2% than in the 1-year arm at 4.1%, and in the control arm it was 0.9%. Consistent with our understanding that trastuzumab-associated cardiomyopathy is qualitatively different from what we see from anthracyclines, over 80% of the patients recovered an EF of greater than 50% after stopping trastuzumab, although 1/3 of these again slipped below 50% on subsequent follow-up. In HERA, patients who experienced a primary or secondary cardiac endpoint did not continue on trastuzumab even if they recovered a normal LVEF. Now, how did these results fit with the reports from the U.S. adjuvant trials using doxorubicin cyclophosphamide followed by paclitaxel and trastuzumab? The first point is that in all the adjuvant trastuzumab trials, cardiac deaths are uncommon, even after years of follow-up. In NSABP-B31 and the U.S. intergroup trial N9831, there was one cardiac death in each trial in the trastuzumab arms. In B31, the difference in severe CHF between the trastuzumab and control arms was 2.7%, and as in HERA, the majority of these patients recovered a normal EF after holding trastuzumab. Of interest also is that in the so-called sequential arm of N9831, in which, similar to HERA, patients started trastuzumab after completing both AC and paclitaxel, but immediately after finishing the chemotherapy, the cumulative incidence of congestive heart failure was 2.5% greater than in the control arm without trastuzumab. In both of the U.S. trials, however, as opposed to HERA, eligibility for enrollment required that patients have a baseline EF above the local institution's lower limit of normal, which in most centers was 50%, not 55%. When clinical risk factors for CHF were analyzed in both HERA and in B31 and in N9831, the most significant predictor of cardiac risk was baseline ejection fraction. In B31, for example, patients with a baseline EF of 50 to 54% were 4 times as likely to develop serious CHF compared to those with an EF that was greater than 55%, which was the cutoff for HERA. Although CHF was lower overall in HERA, the authors also found that a primary or secondary cardiac endpoint was more likely for patients with a baseline EF of 55 to 60% compared with those having a higher baseline value. So how do we put this together to provide the best recommendations and choices for our patients? Taking into account the 3-month average time after chemotherapy to initiation of trastuzumab and HERA, and also the higher baseline EF required for enrollment, the cardiac follow-up data in this report is actually consistent with what we have seen in the other trials. However, HERA and the other large adjuvant trastuzumab trials were started over a decade ago, and today the treatment of early-stage HER2-positive breast cancer is rapidly evolving. We now have simpler, less aggressive 12-week chemotherapy regimens for stage 1 lower-risk disease. In addition, we have preoperative regimens with combined HER2-targeted agents that have improved pathologic complete response rates, but without long-term follow-up. And we have non-anthracycline adjuvant regimens such as the docetaxel carboplatin trastuzumab combination from BCIRG-006. Still, the bar has been set by the report at the San Antonio Breast Cancer Symposium of long-term follow-up data from the joint analysis of NSABP-B31 and U.S. intergroup N9831, in which 92% of the patients had node-positive disease, and the 10-year overall survival is 84%. We are grateful to the authors of the HERA trial for providing these long-term cardiac data in an anthracycline-treated population. As a result, in the adjuvant setting, we have further support that patients with higher risk HER2-positive breast cancer, and importantly also good baseline myocardial function, can be treated safely and with excellent long-term benefit using an anthracycline and taxane-based trastuzumab regimen. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.